A strange thing happens when millions of people suddenly stop feeling as hungry. The grocery cart gets smaller. The restaurant order changes. The late night snack loses some of its power. The beer fridge stays fuller for longer. And somewhere far away from the doctor's office, executives at snack companies, fast food chains, clothing stores, gyms, insurance firms, and pharmacies start quietly asking the same question. What happens to the economy when appetite becomes adjustable? That question is why weight loss drugs have become one of the most important business stories in the world. On the surface, this looks like a healthcare trend. A new class of medications becomes popular. Pharmaceutical companies make billions. Patients argue with insurers. Doctors try to keep up with demand. But beneath that obvious story is something much bigger. Because appetite is not a small part of the economy. It is one of the engines that keeps huge industries moving. It decides what people buy on the way home from work. It shapes grocery aisles, restaurant menus, advertising campaigns, clothing sizes, fitness routines, employer benefits, and even the economics of health insurance. For decades, the modern consumer economy was built around desire. Bigger portions, more snacks, more convenience, more delivery, more indulgence, more reasons to eat when you were stressed, bored, lonely, tired, celebrating, or just walking past the right display at the store. Then GLP-1 drugs entered the mainstream. Names like Ozempic, Wegovy, Mounjaro, and Zepbound moved from medical journals into everyday conversation. At first, people talked about them like celebrity gossip. Who was using them? Who looked different? Who denied it? Then the conversation changed. People started asking why the drugs were so expensive, why pharmacies could not always keep them in stock, why some insurance plans covered them while others refused, why employers were suddenly paying attention, why food companies were watching prescription trends, and why one type of medication had somehow become a threat, an opportunity, and a social debate all at once. To be clear, this video is not medical advice. It is not telling anyone to use or avoid any medication. That decision belongs between patients and qualified healthcare professionals. What this story is about is money, behavior, and the hidden systems that react when people's relationship with food starts to shift. Because the demand for these drugs did not appear out of nowhere. It came from a very old problem meeting a very modern business model. For years, weight loss was sold as discipline. Buy this meal plan, join this gym, download this app, drink this shake, count these calories, cut this food, follow this influencer. And if it did not work, the failure was usually placed on the person. The market loved that arrangement. Because when weight loss is treated like a personal willpower problem, companies can sell endless solutions without needing most of them to work for most people forever. There is always another program, another challenge, another subscription, another promise before summer. But GLP-1 medications changed the emotional frame. They made many people ask whether appetite was less like a moral weakness and more like a biological signal. That shift matters. Once people see hunger as something that can be medically influenced, the entire weight loss industry looks different. A person who has spent years trying diets may be willing to pay a high monthly price for something that feels fundamentally different from another app or another branded protein bar. And that willingness to pay is the foundation of the boom. The economics are powerful because these drugs are not usually one-time purchases. They are recurring prescriptions. Month after month, refill after refill, patient after patient. For pharmaceutical companies, that is the dream. A large addressable population, high demand, premium pricing, strong brand recognition, and a product that many users may continue taking over time, depending on medical guidance, cost, coverage, side effects, and personal circumstances. That last part is important. The business model becomes more attractive when the customer does not disappear after one purchase. A surgery happens once. A pill bottle runs out. An injection pen gets replaced. The revenue can repeat. That does not mean every user stays on these drugs forever. Some stop because of side effects. Some stop because of cost. Some cannot access supply. Some change treatment plans with their doctors. Others may remain on them for long periods because stopping can be complicated And weight management is rarely a simple before and after story. This is where the pharmaceutical business becomes much bigger than a pharmaceutical business. When a drug affects appetite, it touches spending, and spending is where the ripple begins. The first ripple shows up in the most obvious place: food. Not food in the abstract, but the little daily choices that create billions of dollars in revenue. The extra item at checkout, the bigger soda, the second burger, the family-size bag that one person somehow finishes over the weekend, the dessert added because the server asked at the perfect moment, the snack bought at a gas station, not because anyone planned to eat it, but because it was there. Consumer companies are very good at turning small impulses into predictable revenue. That is why packaging matters. Shelf placement matters, limited time flavors matter, rewards apps matter, portion sizes matter. A few extra dollars per customer, multiplied across millions of customers, becomes a business model. GLP-1 drugs do not need to erase those purchases to scare companies. They only need to weaken the impulse. If a customer still goes to a fast food restaurant but orders less, revenue changes. If they still buy snacks but buy smaller packs, margins feel it. If they still drink alcohol but skip the second or third drink, bars and beverage brands notice. If they still shop at the same grocery store but move from ultra-processed snacks toward protein, produce, yogurt, or ready-made smaller meals, the winners and losers inside the store begin to shift. That is why food companies are watching this trend carefully. They are not panicking because every user suddenly stops eating. That would be too simple. The real issue is more subtle. A consumer with a muted appetite is still a consumer, but a different kind. They may become more selective. They may waste less food. They may stop chasing the cheapest calories and start looking for smaller portions with higher protein. They may buy fewer impulse snacks, while still paying more for specific products that fit their new routine. That creates danger for some brands and opportunity for others. A snack company can try to sell smaller packs. A restaurant chain can promote lighter meals without making the brand feel like a hospital cafeteria. A grocery company can redesign prepared foods around convenience, nutrition, and portion control. A beverage brand can lean into low-calorie, alcohol-free, or functional drinks. The money does not disappear. It moves. And in business, movement is where competition gets interesting. Fast food chains are in a difficult position. Their model was built around affordability, speed, habit, and cravings. They became masters of turning hunger into traffic. But if hunger becomes quieter for a growing share of customers, the industry has to work harder for the same order. A person on a GLP-1 medication might still meet friends at a restaurant. They might still use delivery. They might still buy coffee. The social ritual remains. The plate may change. That matters because restaurants do not only sell calories. They sell convenience, routine, identity, time-saving, comfort, and a place to be. So the chains that adapt may not be the ones pretending nothing has changed. They may be the ones that understand the customer now wants smaller, higher quality, more customizable choices without being lectured. The same logic reaches alcohol. For years, alcohol brands have dealt with younger consumers drinking less, wellness culture, mocktails, cannabis competition, and changing social habits. GLP-1 drugs add another pressure point. Some users report reduced interest in drinking. That does not mean the alcohol industry collapses. It means a market already fighting for attention gets another reason to worry. A person who used to buy a bottle of wine every weekend may buy one every other weekend. Someone who ordered 3 cocktails may stop at 1. A few changed habits, repeated across a wealthy customer base, can become a quiet revenue problem. Then comes clothing. This is one of the stranger second-order effects. When people lose weight, they may need new clothes. At first, that sounds good for apparel retailers. New sizes mean new wardrobes. A customer who has not enjoyed shopping for years may suddenly buy more. Brands that handle size transitions well could benefit. But the effect is uneven. Some people buy temporary clothing while their weight changes. Some delay purchases until they know where their body will settle. Some leave plus-size categories. Others enter standard sizing for the first time in years. Retailers have to decide what demand to plan for long before the customer walks into the store. Inventory is unforgiving. Order too much of one size and it sits. Order too little of another and the sale disappears. So, A drug prescribed in a clinic can eventually change what sizes a clothing chain places in warehouses. That is the hidden economy of appetite. It does not stay in the body. It travels through supply chains. The fitness industry has a complicated relationship with weight loss drugs. On one hand, anything that helps people lose weight might seem like competition for gyms, trainers, diet programs, and wellness apps. After all, a large part of the fitness market has always been powered by people trying to change how they look. But the smarter companies see a more layered story. If someone loses weight, they may feel more comfortable exercising. They may want strength training to preserve muscle. They may hire a trainer to reshape their routine. They may join a gym for health, confidence, or maintenance rather than punishment. The pitch changes. For years, fitness marketing often sold transformation through suffering. Now it may have to sell support, strength, and long-term lifestyle. That is a different emotional business. It is less about burning off guilt and more about helping people live in a body that is changing. This could hurt low-quality programs that rely on shame. It could help companies that offer coaching, resistance training, community, and medical-adjacent wellness without pretending to be doctors. The same shift is happening in pharmacies. Pharmacies are no longer just places where people pick up medicine. They are becoming access points in a massive drug distribution battle. When demand runs hot, the pharmacy becomes the front line. Patients call around. Prescriptions are transferred. Supply shortages create frustration. Pharmacists handle questions, substitutions, delays, and sometimes anger from people who feel they are being denied something important. Behind the counter, a larger machine is moving. Manufacturers expand production. Wholesalers allocate supply. Pharmacy benefit managers negotiate formularies. Insurers decide who qualifies. Employers ask what coverage will cost. Patients search for coupons, cash pay options, telehealth clinics, or alternatives. This is where the business story becomes uncomfortable, because demand is not the same as access. A drug can be famous and still unreachable. It can be available in theory and unaffordable in practice. It can be covered for one diagnosis, denied for another, and priced in a way that makes the system feel arbitrary to the person trying to get it. That creates a strange social divide. Some people can pay out of pocket. Some have generous insurance. Some receive coverage through employers. Some are denied even when they believe the drug could help them. Others never enter the conversation at all because the monthly cost is too high. This is one reason GLP-1 drugs became a story about inequality. A medication associated with weight loss in a culture obsessed with appearance will never be socially neutral. It touches health, status, beauty standards, stigma, and money at the same time. For some users, the experience can feel life-changing, not because a number on a scale changed, but because food no longer occupies the same amount of mental space. For others, the trend feels unsettling. They see a society that already pressures people about their bodies, now adding a pharmaceutical shortcut for those who can afford it. Both reactions can exist at once. That tension is why employers and insurers are in such a difficult position. From one angle, covering these drugs could make sense. Obesity is linked with expensive long-term health issues, and employers already spend heavily on healthcare benefits. If treatment reduces future costs for some patients, coverage could look like an investment. From another angle, the near-term expense is enormous. An employer covering thousands of workers has to ask what happens if many people want access at the same time. An insurer has to decide who qualifies, how long coverage lasts, what documentation is required, and whether savings might show up years later, after the person has changed jobs or switched plans. That creates a brutal mismatch. The cost arrives now. The potential savings may arrive later. Maybe they arrive for someone else. This is one of the most important economic problems in American healthcare. The system is not always built to reward long-term prevention. It is built around budgets, plan years, contracts, formularies, negotiations, and risk pools. GLP-1 drugs put pressure on every part of that machinery. They force insurers to ask whether obesity treatment should be treated like a core medical expense or a lifestyle benefit. They force employers to decide whether denying coverage hurts recruitment, morale, or fairness. They force policymakers to think about whether access should depend so heavily on income and insurance design. and they force patients into a market where the same drug can feel like a miracle, a luxury item, a monthly burden, or a symbol of everything broken about healthcare pricing. For pharmaceutical companies, the opportunity is almost unbelievably large, but it is not effortless. These drugs are difficult to manufacture at scale. Demand has been so intense that supply became part of the story. Production capacity, injection devices, active ingredients, quality control, and distribution all became competitive weapons. In a normal consumer market, a company wants popularity. In this market, popularity can become a problem if the company cannot produce enough to satisfy doctors, patients, pharmacies, and investors at the same time. Scarcity also changes public perception. When people hear that a drug is hard to get, demand can become even more intense. Scarcity suggests value. The product becomes something people chase. That chase creates room for telehealth platforms, compounding pharmacies, wellness clinics, discount programs, subscription models, and a whole ecosystem built around access. Some of that ecosystem may increase convenience. Some of it raises concerns about quality, oversight, and whether consumers fully understand what they are buying. The demand is so powerful because these drugs sit at the intersection of several emotional markets: healthcare, beauty, aging, status, workplace confidence, dating, fertility concerns, longevity culture, social media comparison, economic productivity. Very few products can touch that many insecurities and aspirations at once. That is why people are willing to spend so much. They are not only paying for appetite suppression, they may be paying for relief from years of failed attempts. They may be paying for the possibility of being treated differently. They may be paying to feel less controlled by food. They may be paying because the world rewards thinness in ways people rarely say out loud. This is the part of the story that makes businesses excited and society uneasy. When a product changes consumption, investors see opportunity. When it changes bodies, culture reacts. And when it does both, the arguments become personal very quickly. Food companies do not want to say they are worried about people eating less. Restaurants do not want to sound like they depend on overeating. Alcohol brands do not want to admit that reduced cravings could be a business risk. Fitness companies do not want to be seen as obsolete. Insurers do not want to look cruel by denying coverage, but they also do not want costs to explode. Employers want healthier workers, but not an uncontrolled pharmacy bill. Pharmaceutical companies want broad adoption, but they also have to defend pricing, patents, supply, and safety monitoring. Every industry involved has to speak carefully. The consumer, meanwhile, is stuck in the middle. They are told to be healthier, then asked to pay for it. They are told obesity is a medical issue, then sometimes denied medical coverage. They are told to love their body, while society rewards them when that body gets smaller. They are told these drugs are revolutionary, then reminded that long-term use, side effects, access, and cost are still serious questions. There is no clean ending to that tension. The GLP-1 boom can be both meaningful and messy. It can help some people while making inequality more visible. It can reduce certain spending while creating new markets somewhere else. It can challenge the food industry without ending restaurants. It can threaten old diet businesses while creating new wellness businesses. It can make pharmaceutical companies richer while forcing healthcare systems into uncomfortable decisions. And that is why this story is only beginning. The next phase may include pills, new competitors, lower prices in some markets, broader insurance fights, more employer coverage debates, and more industries quietly redesigning products for consumers who simply do not want as much as they used to. Because appetite has always been one of the most profitable forces in the world. Companies learned how to trigger it, package it, advertise to it, deliver to it, upsell it, reward it, build habits around it. Now, for a growing number of people, that signal is being changed by medicine. The result is not just a new category of drugs. It is a stress test for the consumer economy. If people eat less, what replaces those purchases? If they drink less, where does that money go? If they lose weight, who sells them the next version of themselves? If insurers cover treatment, who absorbs the cost? If they do not, who gets left out? And if the most powerful consumer impulse in the world can be turned down, even slightly, then entire industries have to rethink what they are really selling. Weight loss drugs may look like a pharmaceutical story, but the deeper story is about something much larger. Change the human appetite, and you start changing everything built around it.